upper versus lower GI bleeding, overt or the occult bleeding. So there are different terminologies that are routinely used. So when we are discussing the patient who is presenting with the blood in his stool, is basically a patient who is presented with the lower GI bleed basically. What is the difference between an overt or the occult blood? We are discussing the terminology. So overt, when we consider when there are the symptoms or the signs present, patient can see the blood in their stool. Occult is when the visible naked eye examination of the stool did not show the blood. It is not obvious, there are no sign or symptoms, or there are the vague sign and symptoms, then we consider it an occult blood loss. Suppose a patient is presenting with an iron deficiency, anemia, and in his stool he cannot see a blood, so there might be a chance that there is a bleeding from the GI that is in the occult form. So how we differentiate whether this is the upper GI bleed or the lower GI bleed? Basically, we consider an anatomical landmark, which is the ligamentum teres. What is ligamentum teres? You can see here. This is a dramatic. This is a picture that simply shows this is the esophagus. You can see this is the stomach. Then we have duodenum. First part of duodenum, then this is the second part of the duodenum, third part of the duodenum. So this is the cup of the duodenum. Here, when the end of the duodenum, you can see a small structure. This is the ligament of the teres. From there, the duodenum starts, right? So this is the part where we will say that the upper GI ends and the lower GI starts. So just it is a simple classification that we divide it in upper GI and the lower GI on the basis of the ligament of the teeth. So any structure which is below the ligament of the teeth and it causes the bleeding, the source of bleeding is there, so that will be considered as the lower GI bleed. So any bleeding arising below the ligamentum of teeth, either from the small intestine or from the colon, right? So jejunum is a part of the small intestine. So lower GI bleed can be from the small intestine like jejunum or the ileum, and it can be from the colon. Majority of the cases arises from the colon, especially the anorectal region, right? But mostly the lower GI bleed, the source of lower GI bleed is in the colon, and in the colon the most common part is the anorectal region. Anorectal region, like the patients can have hemorrhoids, they can have anal fissures. Most probably older patients can have a carcinoma of the rectum. When we consider the lower GI bleed, almost all GI bleeds, if we'll consider all GI bleeds, 24% of the cases of the bleeding is from the lower GI bleed. Means if in your OPD 4 patients come to you with the bleeding, GI bleeding, then there will be a 1 patient from the lower GI bleed, and there will be chances 3 patients will be from the upper GI bleed. Sometimes we consider just the patient will come to us with the hematochezia. Hematochezia means when there is a fresh blood present in the stools, but it's not like that. Mostly there are chances that 81% of the people will come with the hematochezia, but there are fair chances of 19% that will come with the melena, yani blackish stool, and blackish stool are the blackish color of blood in the stool. When we consider the severity of the upper GI and the lower GI bleeding, basically the lower GI bleeding is less severe compared to the upper GI bleeding. Bleeding stops spontaneously in 80% of the time. So patients come to you with a lower GI bleed, and there are fair chances that 80% of the patients have no other episode of the GI bleed. Mortality is 2 to 3%, and mostly the reason for mortality is the comorbid condition. So this is the general overview of the lower GI bleed. So look at the etiology. What are the causes that can cause the lower GI bleed? So this is the list of the common disorders that you should know These can cause the lower GI bleed, like diverticulosis, inflammatory bowel disease, infectious colitis, neoplasias, angioectasias, benign anorectal disease like hemorrhoids, upper GI sources. Sometimes, any ulcers in the jejunum, in the ileum, or the tuberculosis which resides in the ileum can cause the bleeding GI. So when a patient comes to you with a lower GI, like how you approach to a patient. Obviously, in any clinical setting, we first take the history. You will have to take the history. Then you should examine the patient. And what is the specific attention that should be given is basically to the vitals, volume status, oxygen saturation, and the urine output. It will tell you whether there is a severe bleeding or not. And initial management should not be delayed. So these are three main pillars for the management and approach to a patient who present with a lower GI bleed. Thorough history and examination should be done, and specific attention to the vitals should be given, and if patient needs management, should not delay the patient for the investigations. So if you consider the history, what is supposed to be asked in the history in a patient who comes to you with a lower GI bleed? First important thing is to ask whether it is fresh or blackish in color. So most of the patient, 80% of the patient present with the hematochezia. Then the second thing is to ask whether it's a chronic or a acute. For how long this is going on? It's on a first episode or this is going on for the weeks and months or years? What is the age of the patient? Is he in the older age group or he's younger? Mostly we consider 50, above 50, and lower than the 50 or the less than the 50 years of the age. Is this bleeding is painless or a painful? Does patient feel any pain when he defecate or not? Associated other symptoms, you will have to ask about whether patient is having fever, whether patient is having any weight loss, other things that are the alarming symptoms that will suggest you whether patient is something serious going on, like malignancies or the tuberculosis. They can cause the fever, they can cause the weight loss. Whether patient take the drug history, is patient taking any drugs, specifically NSAIDs, antiplatelets, anticoagulants, because coagulopathies or the ulcers can be the reason for this GI bleed. The person who is taking anticoagulant, patient is on the warfarin, there are fair chances that because of the coagulopathy, the patient can bleed from the GI. So we have discussed the prior GI bleeding episodes. The patient has an acute chronic condition. Comorbid conditions are very important. Ask about the comorbid conditions like ischemic heart disease, diabetes, hypertension. The person who is bleeding profusely and patient is having ischemic heart disease, the main reason for mortality will be that MI. The patient can go into hypertension. The patient, there are fair chances the cardiac disease can present in the form of myocardial infarction. There are fair chances the patients who already have multiple disorders, already multiple comorbid conditions are there are chances the patient go into a multiple organ failure. So when you are taking history, suppose consider if a person who comes to you below the age of 50 years. So what are the causes? You can see here: inflammatory bowel disease, infectious colitis, like a patient who present with a fever and acute kind of the blood in stool, basically have infectious colitis. Anorectal diseases like hemorrhoids, anal fissures, these are all common below the age of 50 years. If a person is above 50 years, these are the main things that should be in our priority list to rule out, like diverticulosis, angiodysplasias, neoplasms, malignancies. Really, we consider that malignancy is present in the older age groups, and ischemic colitis. If we consider the symptom of pain in the history, So most of the time the painful bleeding is due to anal fissures because of the ischemic colitis, inflammatory bowel disease. These patients have lower abdominal pain, they can have fever, and they have more symptoms as compared to the hemorrhoid patients. So painless bleeding is usually present in the internal hemorrhoids, diverticulosis, and angiodysplasias. These are the conditions in which patient will bleed, but there will be no pain on the defecation. There will be no abdominal pain in these patients. So if we are going to discuss a few differentials on the history basis, like diverticulosis. Patient of divertic, I will show you the picture of diverticulosis when we will discuss the colonoscopy. The patients with the diverticulosis who have a diverticula in their colon, they present with a maroon or the bright red blood, that is hematochezia basically. Their bleeding is painless, there will be no pains, and that is spontaneously. They will bleed, the bleeding spontaneously will stop. Then after a few weeks or months they again bleed, and the bleeding can spontaneously will stop. This is common in the older age group. Angiodysplasias. Angiodysplasias are basically abnormal vessels. So these patients present with the painless bleeding, again like diverticulosis, their bleeding is really painless. It is common after the age of 70 years. So mostly this is a disease of an elderly group. Occurred or the massive blood loss can occur, right? So occurred blood loss can occur, and there can be a fair chances that there is a massive bleeding and patient bleed profusely. And it is very important, if a patient who is elderly in group and they have comorbid conditions like ischemic heart disease, diabetes, hypertension, or anything else that is comorbid is there, then there are fair chances the condition can get more severe in these patients. Neoplasm malignancies or benign lesions. So both benign polyps and the carcinomas can cause the bleeding, right? So neoplasm, they can be benign, there can be malignancies. So benign are usually polyps, the colonic polyps. They both bleed. There are fair chances that these patients have a chronic occult bleeding, right? They just present with iron deficiency anemia. They can present with the anorexia, weight loss, low-grade fever, and after the multiple investigations, they turn out to be cases of malignancies or the colonic cancers, rectal cancers, or malignant polyps. There are chances the bleeding can be intermittent, mild, or hematochezia, and sometimes that can be a profuse if there are more vessels in the malignancy. And obviously you will have to correlate that these patients are having fever, weight loss, or anything else. Like sometimes these patients directly present with the metastasis, so there can be chances that you will get the other findings of metastasis in the lung or liver or any brain, so they directly present with those symptoms. The fourth one is inflammatory bowel disease. Inflammatory bowel disease, Crohn's, and ulcerative colitis. You might have read all these things. Most commonly, the patient who presented are the ulcerative colitis. Crohn's can present with upper GI bleed, but ulcerative colitis more commonly present with the upper GI bleed. They present with the diarrhea. The associated other symptoms with the ulcerative colitis are the diarrhea. They can present the hematochezia, profuse bleeding. They can present the occult bleeding. They have abdominal pain, tenesmus, and urgency. So they have abdominal pain. All the symptoms of inflammation will be there. They have abdominal pain. There can be a chances of fever, tachycardia, tenesmus, urgency, diarrhea. So all these things will be present, which are not present in other condition. Here you are a strong differential will be the infective colitis, like the Shigella, Salmonella, and all this. So those patients have a high grade fever, and these patients really don't have a high grade fever. The most common one is the anorectal disease, hemorrhoids. This is very common. They usually present the painless bleeding. The patient just bleed after passing the stool. That can be a mix with the stool or dipping into the toilet bowl, and it is painless. It is small bleeding, and sometimes that can occur in the small fissures, right? So these are the two common conditions in the anorectal disease. Sometimes there are the this is the benign disease, right? Sometimes there are the rectal carcinomas or the anal carcinomas. They can bleed, and the bleeding can be the painful or there can be a painless. It depends upon whether the tear is present or not, inflammation is there or not. Ischemic colitis. So what is ischemic colitis? Ischemic colitis is basically colitis. It's inflammation of the colon, which is usually present in the elderly group, the patients who are more than 75 years of the old age. Those who have atherosclerosis, and they present as the bloody diarrhea with a mild abdominal pain. So usually the symptoms are they have ischemia of the colon, right, because of the excessive atherosclerosis. So they usually present with a mild diarrhea that has blood in it, and sometimes they just have a profuse bleeding, and they have a mild abdominal pain. So pain is not that severe until and unless there is a thrombosis of the vessels. After taking the history, you have few points of differential diagnosis in your mind. You just get an idea whether it is a benign disease or it is a severe disease, malignancy, or it's an infective colitis. So now, after making a differential diagnosis, you should go for the physical assessment, physical examination. The most important thing in a physical assessment is vitals. A patient who's bleeding, and especially a patient who's bleeding profusely, their blood pressure, their pulse should be recorded. If there's a postural hypertension, whether the patient has dizziness, postural hypertension when you are taking the blood pressure, in changing the posture, like patient is sitting, taking the blood pressure in a sitting position, and then again taking the blood pressure in a standing position, and if there is a difference of the blood pressure that is significant, then you will say this patient is having postural hypertension, and that is suggesting that patient is bleeding profusely. The other examination point that are very important is to rule out the liver disease. So you should be clear that patient is not bleeding from the varices or anything else that is profuse and coming into the stool. Are there any physical signs of malignancy, like the signs of weight loss? Are there any abdominal masses which you examine on the abdomen? And the third important aspect of the physical assessment and examination is basically rectal and stool examination. In a stool, you will get an idea the patient is presented with hematochezia or melena, or on rectal examination you will get an idea whether there is any mass in the anal part, any hemorrhoids you can examine. So this is very important. So these are the three important components of the physical assessment to rule out what is going on. If a patient is present with a painless bleeding and it is small in quantity, and on stool examination and the rectal examination you can easily find out the patient is having hemorrhoids. After doing the physical examination, narrow down your differential diagnosis and then go for the laboratory assessment. Laboratory assessment, the few investigations are very important. General investigations, the basic investigations like blood CP. Complete blood count is very important because you need to know the hemoglobin of the patient, the total leukocyte count, and the platelets. Platelet will tell you whether the bleeding is secondary to low platelets. TLC will tell you if there is any infective processes going on, and HB is very important. Hematocrit is very important to find out if patient has a severe blood loss. Blood type and Group's mesh should be done. So if patient require transfusion, that can be given. Coagulation factors like PT and APTT should be prothrombin, and obviously APTT should be done to rule out if there is any coagulopathy present in a patient. Blood urea nitrogen and creatinine ratio is usually done. This will tell you if you have a confusion and you don't know whether the source is upper GI or the lower GI, then there are fair chances that the increased ratio will suggest there is a upper GI source. It means that blood urea nitrogen is higher than the creatinine. Then the LFTs, liver function tests like bilirubin, albumin, INR to assess for the hepatic synthetic functions. Liver is functioning normally, or this is a case of chronic liver disease. Then we go to the procedures. Those are mostly invasive, or those are specifically help in the diagnosis, like endoscopy and sigmoidoscopy. This is simply a proctoscopy and a sigmoidoscopy when we examine up till the sigmoid with a sigmoidoscope. Nasogastric intubation is sometimes done. It is a procedure, so I have mentioned here in a different category, because if patient is bleeding from stomach or the esophagus, then nasogastric intubation will tell us that there's a blood in the stomach, so the source is there. Technetium scan is there. We'll discuss it further. Angiography and colonoscopy, these are very important tests. We will discuss one by one. So when we do the procedures or the specific diagnostic test, digital examination is very important. It will help you tell us if hemorrhoids are there or not, or any anal fissure you can clearly find out. Endoscopy is basically, we say, proctoscopy and sigmoidoscopy. It is done, sigmoidoscopy is done up to the extent of the sigmoidoscope, and most of the time the sigmoidoscopy is done to look for the anorectal disease up to the sigmoid region. Inflammatory bowel disease or the infectious colitis. So most of the time when patient has anorectal disease, like when you did the digital examination or the proctoscopy and you have find out the patient is having hemorrhoids, or patient is having some suspicion of the rectal carcinoma or inflammatory bowel disease that is just involving the rectum, then the sigmoidoscopy is sufficient for those patients. After the sigmoidoscopy, we have a colonoscopy. Colonoscopy is mostly done investigation. So it is an invasive procedure, obviously. It is really performed if the bleeding stops or occurs at a lower rate. It allows identification of the angiodysplasia, tissue biopsy, and therapeutic interventions with the electrocautery heater probe or the laser therapy of the active bleeding. It is not helpful during the messy bleeding. So if patient is coming to with a bleeding that is massive, this is continuously bleeding, you cannot go for the colonoscopy. It will not be helpful. So when the patient stabilizes, the bleeding has stopped, then you can go for the colonoscopy. This is the drawback. Another thing is, what is the good about the colonoscopy, that you can do the procedures, like you can do the therapeutic procedures, you can take the biopsies, you can do the electrocautery, and you can do the laser therapy for the active bleeding. You get the polyps, those are bleeding, and you can do the electrocautery heater probe. You can use the electrocautery heater probe to stop the bleeding in these patients. So therapeutic options can be done with the colonoscopy. So that is the positive point about the colonoscopy. Here I will show you some pictures that is done during the colonoscopy, like how these lesions can be seen on the colonoscopy. In the first picture you can see this is the angiodysplasia. Angiodysplasia are basically, these are the abnormal vessels. So you can see here there is a branching of the vessels, as there is a bunch of the vessels which is present. So there will be a oozing from this bunch, and these are diagnosed as a case of angiodysplasias. This is a picture of the diverticulum. You can see the small holes over here. So these are the diverticulum. The diverticular are basically pouch-like structures in the wall of the colon. Most of the time they are silent. They don't do any symptoms, but rarely they can present with the bleeding. So, and bleeding stops spontaneously as we discussed. So this is the picture which can be diagnosed. The diverticulosis can be diagnosed easily on the colonoscope. This is malignancy. This is basically a CA colon. So you can see a fungating mass which is arising from the wall of the colon, and you can see the spots of the bleeding on this mass. So this is can easily be diagnosed on the colonoscopy, and you can easily take the biopsy and diagnose and confirm the histopathologically. You can confirm the diagnosis. This is a colonoscopic picture of inflammatory bowel disease. So you can see this is basically a case of ulcerative colitis, and you can see the wall. This is the colonic wall, and it has multiple ulcers, and you can see the bleeding spots over here. So multiple ulcerations you can see in the inflammatory bowel disease. Technetium-99m RBC scan is a procedure which is performed in active bleeding to detect the source of bleeding. Well, when there is a profuse bleeding, there is an active bleeding, you can go for the colonoscopy. So then you will have to go for the technetium-99m RBC scan. It will detect the source of bleeding. Can also be performed for the intermittent bleeding. So there are different different advices for the patient, but most of the time we do this when we don't get a patient which is not stabilized, who's continuously profusely bleeding, and we cannot find out where's the source. Then we go for the technetium-99 scan. Angiography. This is also done in the active bleeding, and it is investigation of choice for a patient who is continuously bleeding. Selective angiography indicated for the massive ongoing lower GI bleeding or with recurrent bleeding with negative colonoscopy findings. So if the patient is continuously bleeding, you can go for the angiography. Or a patient who is bleeding and on the colonoscopy you didn't get intermittent bleeding, and patient is have gone through a colonoscopy examination and you didn't get anything on that, then you should go for the angiography to find out the source of the bleeding. Can be used as a therapy coil embolization, alcohols and vasoconstrictors. So this is a procedure in which therapeutic options are available. So therapeutic procedures can be done. The treatment for the different disorders of colon can be done, and it is very effective. If you got the finding what is the problem in the colon, then it is very good. You can get a therapeutic option. So after diagnosing a patient, investigating, doing a diagnostic procedure, so what should be how you manage the patient? So let's see how we manage the patient. First important thing is the risk stratification. If a patient comes to you in an emergency department, you should do a risk stratification. In a risk stratification, basically you look for the pulse rate. If it is more than 100 or not, means there is a tachycardia or not. If the systolic blood pressure is on the lower side, which is less than 115 millimeter of mercury, patient has associated syncope. If he is feeling the symptoms of syncope or already had a syncope. Blood per rectum during first 4 hours of evaluation. So there is bleeding going on. Patient is on aspirin, so there are fair chances the patient can bleed more. 3 or more comorbid conditions present, like patient is having ischemic heart disease, or patient is diabetic, or patient is having hypertension, or patient already has a chronic liver disease or any other comorbids. So you will have to calculate, every condition has 1 point and you will have to calculate the points. If points are more than 6, 4 to 6 or more than 6, this is a high risk patient. There are more chances that there will be a severe disease. So do the risk stratification. Initial management should be given to all patients. So any patient who comes to you with the bleeding, always do ABC. Just look for the airway, breathing, circulation. You should have to check the blood pressure. You will have to see the oxygen saturation of that patient. Always, if there is a profuse bleeding, IV access should be given. Cannula लगा दीजिए आप उनको. Fluids are required, give the fluids. Hematinics की required है, give the hematinics. And if patient is serious, he's hypotense and there are the other parameters, then you should go for the ventilator support in this patient if there is a severe bleeding. Now suppose the patient is coming to you with a massive ongoing bleeding with hemodynamically instability. The urgent angiography is indicated. Obviously you cannot go for the other investigations and colonoscopy. So urgent angiography should be done. If colonoscopy does not reveal a source but bleeding continues, then tagged RBC scan should be done to localize the bleeding. Right? These are the points of management we are going to discuss. In the massive bleeding, urgent angiography, and if a patient is bleeding and there's an intermittent bleeding, colonoscopy is done and their source is not identified, then you should go for the RBC scan. If the colonoscopy does not reveal a source, the bleeding stops, then observe the patient. So these are the three important points in the management diagnostic point of view. Massive bleeding, go for angiography. If colonoscopy can be done, go for the colonoscopy. It means that bleeding has stopped. You should go for the colonoscopy and find out what is the wrong with the patient. It is an inflammatory bowel disease, it's a malignancy, it's a tuberculosis, or something else, angiodysplasia, diverticular disease, whatever is there. If patient is diagnosed on colonoscopy, that is well enough. If you didn't get anything on the colonoscopy, go for the RBC scan. If colonoscopy is done but it did not reveal any source, you didn't find anything, colonoscope was perfectly normal, then just stop. And the bleeding has stopped, just observe the patient and just give the time to the patient, just monitor the patient for the vitals and see. Because most of the time we have discussed 80% of the patient, the bleeding spontaneously stops and sometimes we cannot identify the source. So this is the way of management. Do we need the surgery? Now the point is, do we need the surgery? Yes, sometimes we need the surgery. Surgery is done on the patients who have failed the medical, colonoscopic and angiographic interventions. Like patient has a malignancy, right? And in the cases of malignancy, you need the surgery. Or a patient who has an inflammatory bowel disease, and there are some conditions like there's a megacolon, there's a ongoing active bleeding which cannot be stopped by the drugs, medicines. So our angiographic interventions, then we should go for the surgery. Or there's an ongoing bleeding which is more than 4 units of the blood per 24 hours, means you need more blood transfusion. Patient is continuously bleeding and you will have to continuously transfuse the patient, which is more than 4 units per day, then you should go for the surgery. It's better. Efforts should be made to localize the source prior to surgery. So it's still better that you should identify where is the problem. You will have to localize the problem, and you have made the diagnosis whether it's an inflammatory bowel disease, it's a malignancy, it's an angiodysplasia, and the bleeding is ongoing, bleeding is not stopped. Patient needs more blood transfusions, 4 units per day, then you should go for the surgery. What surgical procedures are usually done? There can be a targeted subtotal colectomy. Means आप टारगेट करते हैं एंड देयर इज अ सब टोटल जो है वो कोलेक्टमी करते हैं. ब्लाइंड सब टोटल कोलेक्टमी भी हो सकती है, ब्लाइंड सेगमेंटल कोलेक्टमी भी हो सकती है. बट these two conditions, the second one and the third one, has a high mortality. So it should be a targeted. So it shouldn't be the blind. So at the end, what is the conclusion of approach to a patient? Always try to diagnose the source of bleeding. By the history, by your examination, by your investigations, try to find out where is the source of bleeding in the lower GI. But never compromise on the resuscitation. So, initially start the management immediately. If patient has low blood pressure or tachycardia, or we have done the risk assessment, and if it is on a higher risk, the initial management should be started without any delay. If there's any coagulopathy present, correct it. Make sure, remember that patient can die from the comorbidities, right? We have discussed the main issue like ischemic heart disease. So patient can die due to ischemic heart disease because of the massive bleeding. GI bleeding requires a multidisciplinary approach. So critical care, medicine, GI, radiology and surgery, everybody should be involved in a patient who is presenting with the lower GI bleeding. This I added a YouTube